So, finally, we have arrived at the end of this symposium. I'm quite happy that all are still here. Seemingly you are still interested in drug hypersensitivity. I come from practice. I'm a practitioner. I work in Löwenpraxis together with a few other doctors, half of them pneumologists, the others allergologists and immunologists. I work in a clinic where I sometimes see severe cases, as you do see it. And one day a week, I'm clinical consultant in ADR-AC because I'm still in the heart, partly in the lab. I had to realize you can't do both, and Daniel is doing it so much better, so I quit pipetting, but I still consult, and I think together this is quite a good team to offer you services. So if you are interested in what you heard, there's a QR code, you find all the handouts there. They will also be projected afterwards. I'm also employed, as you have just heard. I'm not the owner of ADR-AC. Sometimes it's mixed up. I'm working there because I like to work there, and I would earn much more in my private practice than in ADR-AC, but I prefer the content that I learn, and I like the both sides. And Pierre, I think, is doing the same here, and some of you might also be interested in a work like this. But I'm mainly clinician. What you have heard till now covered some theoretical thinking about how drug hypersensitivity reactions actually occur. That has Werner done. You learned a lot about the cyto-LTT. You have seen several cases from around the region. And I would now want to introduce a way in how you can perform drug hypersensitivity testing in your practice, because sometimes it's really limited to the local centers, and this means there's only limited access for our patients, and sometimes the general practitioners are not referring them because they think it's firstly so long, and then it takes so many visits there, and my people are always lost, my patients are lost to follow up. So that is sometimes a problem, and it's really overwhelming when we worked in Inselspital and all the patients came from all around the region and sometimes even beyond that. It is really hard to work up all those as only one team, and I hope that at some time point we see the allergologists of Switzerland as one team to work up this, because we are the only ones who care for those patients. Several doctors have led or have given medication, and it's a true iatrogenic disease. We are the cause of this disease, and most doctors just refrain from working it up, and we should make an access as easy as possible. So what you will hear now is this accelerated diagnosis approach. I just try to lead you to the current process on how it works. At least I see it in Lucerne, and as I hear on phone calls from you. First of all, some doctor has to realize this is now a drug allergy. That is the first step. Some don't realize, they think it's measles or something else, and then they give another antibiotic and another, and we end up with multiple drug hypersensitivity or whatever. So somebody has to have the idea that a certain, mainly skin disease, but it can only be solely a hepatitis. That is also important. It needn't always be the skin which is involved. And then some workup is done locally with the GP, with the internal medicine wards. So if there's a skin involvement, please take a picture. That's very good on the long run, because this is only be possible in the acute phase. And I always try when I'm called, please take out your phone, take a picture, because everyone has for everyone it's possible to take a good picture now, because all of our cell phones are good cameras actually. And if possible, and you heard a lot about the acute phase lab that you can do look for eosinophils, not just the differential blood count, but with eosinophils. There are different differential blood counts. You need to have the eosinophil number, liver enzymes, and you heard about the severity of the disease clinically, and the only slightly elevated CRP. So CRP is also a good value to be taken during the acute phase. And this all together helps you as a specialist to have kind of a severity grading. What am I confronted with? Is the skin manifestation only the tip of the iceberg? Is there actually several organs involved? How severe is the organ involvement. So this is also very important for us, and it can only be done in the acute phase. We cannot reproduce it 4 months afterwards and kind of stimulate, or we provoke the patient and try to have the same picture, which is very medieval medicine, I would say. And then there is corticosteroids. They can be given in whatever form because the eosinophils are very responsive to corticosteroid treatment, and this is usually done by the treating physician and not by the allergologist. We are too less to care for all these acute patients. And some use the service of AHA. There is a brochure which has been written also together with Jean-Christophe Gobert from Geneva, and it gives an overview for the patient because those are usually most disturbed, and you heard about the anxiousness of patients who and even of the GPs. They don't want to give any medication to this patient again, and this is quite informative and helps, but it shouldn't stop at the information. It should go on a diagnostic journey, and I call it journey because most patients and GPs have the impression this is quite a long-run journey that they have to embark on. It usually starts off with a practitioner, a physician from the hospital who has the contact and realizes this might be an allergy, a drug allergy. And then he or she is referred to the local allergologist. Usually the referral letters are not so precise, so you actually don't know what it's all about. So you first talk to the patient, and then you have to prepare. If you want to do testing, for most probably skin testing, you won't have everything around. It's just ADR has had 680 substances on shelf. You won't have in your private practice, at least not to be injected all the time. So you have to prepare. He comes a second time. And then there's a delayed reading. Either he or she comes around, or you have contact via whatever virtual media you use. You can also have a look at the skin, but usually they come again. And then you discuss about the results, which is 4 to 5 consultations up till now. If you're very lucky, you have first of all established a diagnosis, secondly have defined an alternative. And this is most probably more important to the patient. What can I take in the future? And it's interesting that it was a drug allergy and what has elicited it, but it is even more interesting, what can I take in the future? So then it starts off after result discussion that a blood sampling, which needs to be fixed with ADR, so it's not at the same day. This is another appointment to take the blood and then to discuss the blood results again, and made then a 1 or several day provocation test. So you might end up with 8 consultations, and not a small number of patients is lost during the journey. They just don't show up again. It's just enough. First of all, it was very expensive. I had a discussion. They still don't have a diagnosis. I don't know my alternative. I just give up. And this is what I encountered in my practice. And I can understand it. If it would be necessary for me to come to a doctor 8, 9 times to finally get the diagnosis, and then he goes back to the practitioner normally and talks again about what can be done in the future. So this is then maybe the 9th or the 10th consultation for the same problem. And the patients don't actually feel sick at this time point. They hopefully have recovered from their allergy. They are completely normal, but they run to the doctor like every second week. And this was something we were thinking about on how we can change it. And this was not only within ADR, but this was within the practice. Because our patients usually, even with the lung doctors, they are not used to come around for so many times in such a short period. And this is why the burden of disease can somehow be lower than the burden of diagnosis. And this is something that we have to think about. If the patient ends up midway and thinks, oh, now enough, I had now more consultations for the diagnosis than during the whole process of the acute phase, I just give it up. And I hope we can shorten this in the future. And this is what we would call accelerated diagnosis in drug allergy, or AiDA, or as Matteo would say, a symphony in medicine. I like it, so it's kind of coined a way. It's only a process. We try to show a process. So it starts again with a suspicion of a drug allergy. But now you contact your local allergologist. So there is the first consilium without the patient running around. So the doctor encountering the drug allergy is calling his or her allergologist of trust. And then they talk. And what we then hand out is a questionnaire. It's a questionnaire quite simple, so we get the information you heard before. So it guides a little bit the talking between the GP and the patient, and is written so the patient can actually fill it out alone also. But it can well be done at the GP's level. And we then try to define if it is actually a delayed type, as we focus today on LTT. To then have contact with your lab of trust, which is, you don't have much of a choice in Switzerland for this specific problem, and you then discuss, the allergologist discusses with the lab on what would be the best choice of substances being tested. And here I want to stress the alternatives. This is the only thing I would add to what you have shown before. You should also include the alternatives to then make a safer provocation, because in the end, most probably you will provoke with an alternative, and it would be good if you have tested the alternative also in at least 2 test conditions. That's why you do skin tests with several substances, and you have 3 slots for every LTT, so try to use them. And then the blood sampling, which is usually done at the allergologist's office, but it can be done in the lab. It can also be done at the GP, but he or she has to be clear on what blood has to be taken and on the amount. So if there's a good collaboration, it can even be done as the practitioner, which means the blood arrives at the lab while the patient had not had an appointment with his allergologist. It was all done by the physicians working together, him or her filling out a questionnaire, and the blood is the first thing arriving at, let's say, the allergy side, which is now this red rose side on the right. Then when the cyto-LTT results arrive, which is, I've put 3 weeks here to have 1 week extra, so the result is definitely at the allergologist. And then I would suggest again a consultation if not everything is clear. This is what Werner has said and what Daniel has said. You can call us and we can talk about cases which are not fully clear to you. Again, before you see the respective patient for the first time. So when you see the patient, you hopefully already have an idea, at best already a diagnosis, where you then can perform, if possible, skin tests, which is not always possible. If it was a very severe reaction, you won't want to provoke with skin testing again a flare-up. And I must say at this time, but AGEP is extremely prone to relapse even after those small doses, as well as all the other severe skin diseases that you can have with drug allergy. But with AGEP, I tried it twice, I failed twice, I'll never do it again, because it's a full-blown picture. It's not at the test site. What works quite well is epicutaneous testing. And the delayed reading you can again do virtually if you want, or you can see the patient, and then he or she can come around for provocation testing, which most probably will be with the alternative. Only rarely, and if you're very secure, you will try to rule out drug allergy, because all tests were negative and you are not convinced. But mostly provocation testing is to show tolerance and not to prove allergy. And then you hand out an allergy passport to the patient, write the report back to the family physician, who can then see the patient, hopefully is very happy as the patient as well. And they talk about future stuff that is no longer related to drug allergy. Which means you end up with 4 appointments. And the most important is, when you see the patient for the first time, you already have a lot of information. But you, of course, also need information. So the first process is quite important when you talk to your local physicians. And this will also intensify this collaboration. And I hope that in the end, with a lower number, more patients will embark on this journey, because not such a small number of GPs are quite reluctant to send it. That you do this, and then you I just avoid, I just do something else. And to make it simpler is a way, hopefully, so that more people actually try to get the diagnosis. This is in this small leaflet in the middle, and it is intended to be shown so that it's not too complicated, but that it's clear to the patient that the good information leads to less contacts and less consultations. And compared to what we have done before, or what we are currently doing, it has, for all participants of those process, it has advantages. I won't read it all, you can read it also at home, but most of them are quite obvious. And in the process which is more streamlined, and where the lab can be a facilitator, and especially a facilitator for you, we still see us as part of the allergology community. We don't open so much up to the GPs. We don't offer our serological service to GPs or whatever and try to bypass allergologists. We want to have close collaboration with you, and we want to have as much patients as possible being worked up in a reasonable time. And reasonable time means within the process, but it also means entering into the process. As you have learned before, sometimes it's very important to be fast. And sensitivity is best within the first 6 months after the reaction. And in certain severe reactions even earlier. So a streamlined, fast process can help in finally getting a better sensitivity. Even if you do the same test just 6 months later, you might lose some of those patients. So with this, 8 versus 4 patient consult, so halving the time, and I'm doing this currently all the time now, and it's quite satisfying to be sitting there, the patients coming in, and I already have a clue. I already have a clue what is going on here, and some patients were really super happy that they oh, you know so much, can I come to you, can you be my GP? So some are really happy about this, even if I'm only a specialist and I only work for this one problem. But I sense that they finally feel happy, there is someone who knows what's going on. And in some, the older process seemed like, oh, they're just testing around and by luck they find the reason. So I hope that this helps also in empowering our subject, because this is also important. We also need young doctors being in our field, and I feel that streamlining and being faster and empowering our subject is important here. So with this, I won't tell you anything more about the process. I hope you try it yourself. There is a way or a recipe on how to do it, and if you have any questions, please contact us, Werner, Daniel, me, or our homepage where you find all the information. Thank you very much.
That's one very important remark to make. Why would we prefer the cytoediting first, which is quite opposite what you learn. First, many of you don't have all the substances. You can't test. So you have to send it somewhere, and then you have to wait sometimes for months or 10 months. You get. And the second, more important one is that our test is more sensitive than the skin test. We have compared it with amoxicillin, where we have gotten the information whether the skin test was positive or negative, and our test was in highly reliable cases, let's say 80% positive. The skin test was 40 to 50% positive. That means it's better. The skin test is not so good, basically. It's done everywhere a little bit differently, and do you know the concentration always for clinical makes skin test? And how to do it. So it's not such a positive test. I think that some centers can do it quite well, but basically our in vitro assays is more exact. We have difficulties. We discussed it already. We discussed low positive values, but there we get your feedback. It's something different if you get an entity which 4 or 5 cytokines are elevated and strongly elevated. You see then the data, or you get an entity 1 positive, and we were not sure, you are not sure.
then it's different. Then I would very much favor, for example, that you do skin testing if possible. But if you get a very good, clear result, I am opposite to him. I think you should be, you can omit skin tests then. And I prefer you to test the alternative. That is your business. Not to skin test around with things that you don't know, but to offer the patient the alternative. Look, we have a quite good sensitivity. We believe that you are allergic to this. We have our diagnosis is based on this, and this. We write it on the report, but now let's see if you tolerate the next drug, this cefuroxime. You are allergic to amoxicillin, but I would like to see if it's, and then give it to him. You do it, and then you are satisfied because you did something clever. You didn't fool around, and actually you got quite rapidly your result. So our test is more sensitive, and whenever you speak with someone about how to proceed in laboratory diagnosis, they will always recommend you do first the more sensitive test and then the specific test. And here our test is more sensitive. It's quite specific, it's very specific, over 90%, but we have some borderline problems with the lower affinity, with the low, some lower odds. Okay?
Okay, now it would be actually a discussion round. So you can come up with whatever you want. Is there anything on your heart or on your back?
I still have to ask these young people about drug allergy. I make an examination. When I go.
Yeah? So is everything clear to everybody?
Do you have any data about bat and COVID vaccine in urticaria? There is something new now that we have.
So, for COVID vaccine bat, we developed this together with the CHUV. And actually, at the beginning, we tested so many people were not vaccinated, and the positivity in non-vaccinated bat was really close or even zero. And the sensitivity and the correlation with skin test was really excellent. Then, after 1 year, when everybody became vaccinated, I'm not so sure about the specificity anymore. What we did see, for example, we observed also, so clinicians observed chronic urticaria due to the third booster. And then, no, but we see in the bat really high response in this patient, really extremely high bat. And also not only to the vaccine itself, but also to cross-reacting substance like polysorbate 80 and 20, and this usually before we didn't see this. So we don't know if it's maybe a constant exposition to this polysorbate, because you find this polysorbate everywhere, that the vaccination has, that maintained. This is a hypothesis. We also try in 5 cases from Ticino also some Ceubat. They were really borderline or really negative. So it's not like a traditional chronic urticaria where we see a positive bat in at least 50% of the cases. So we see there is something that happens. It's what we see with and positive bat, something that is immediate together with chronic state of the doesn't make sense. But we do see actually this really high bat. We were expecting positive Ceubat, but we don't see it. So the interpretation now it's difficult. So if you have some inputs, or they are welcome. There are also other people working on this, also, in Geneva and elsewhere. but
So
it's
in
still
short, we don't know very much.
no. I think it's still important if you have a patient that did a reaction to the vaccine to do a BAT. I think it's still
but that's
important. Yeah.
much less.
But it's much less, and now I don't know with the new booster of the new sequence. The new sequence will have no influence because the sequence is inside, and I don't think that the sequence is recognized. And but for the chronic urticaria, this I don't know.